Good evening, everyone. This is another webinar of the Academy of Nutritional Medicine's AONM. We're absolutely delighted and honored to have Dr. Robert Bransfield with us here this evening, all the way from the US in New York. And he'll be talking about infectious diseases, mental impairments, and global instability, and the association of those with infectious diseases. As I'm sure you all know from past webinars with him, he's a tremendous specialist in that field. I'll just introduce him very briefly, and he'll add in anything that I haven't included. Dr. Bransfield, MD, DLF-APA, is board certified by the American Board of Psychiatry and Neurology in Psychiatry, and is a distinguished life fellow of the American Psychiatric Association. His primary activity is an office-based private practice of psychiatry. He's the past president of the International Lyme and Associated Diseases Educational Foundation and the New Jersey Psychiatric Association. He's held a number of administrative positions with hospitals and organizations involved with health, mental health, and community-related activities, and has received multiple awards. He's a clinical associate professor of psychiatry at Rutgers and the Hackensack Meridian School of Medicine. Many of the patients that he sees have been found to have infectious disease contributors to their psychiatric symptoms, and that's what we'll be hearing about tonight. So, Dr. Bransfield, over to you. I'll just mention to everyone, please do put your questions in the chat or in the Q&A, and we'll have ample time at the end to answer them. So thank you very, very much again, Dr. Bransfield.
All right, thank you, Jillian, and I'll thank you for having me. And this is a somewhat different topic than I usually talk about. That's my disclosure. Usually I'm talking about clinical issues, but this goes a little bit beyond that. So I hope everybody can see my slides. If not, let me know. This is an article I did over a year ago, Microbes and Mental Illness, and that looked at the whole field. It was a review article looking at what are the infections that contribute to psychiatric illness. And then we looked at certain conditions, the 5 conditions that cause most mental disability, which was autism, schizophrenia, bipolar, depression, anxiety. And then we also looked at suicidal tendencies and aggressiveness. And I'll make some references to this article in the course of this discussion. Now, today is based on my most recent article, which is the association between infectious disease, mental impairments, violent behavior, and global instability. It was in Medical Research Archives this year. Now, this slide basically summarizes everything I'll say, and then I'll go in detail with each one of these steps. And a lot of issues we deal with are like a row of dominoes or that interact, or sequence. And I'll look at this sequence and expand it, and then I'll come back. And this is basically the hypothesis that I have. So basically, I'm connecting infectious disease with global instability. And how am I doing that? How do those things connect? Now, it can start where when we have compromised environments, that's conducive to an increase of infectious diseases. And then because there's more pathogens, be those zoonotic or animal-borne diseases where they can be in a host, animal host, and then they go back and forth, and it affects humans as well. Then we get these infectious diseases. Then there's this pathophysiology that some of which involves the immune system, causing biochemical and physiological changes that can result in mental impairments. Now, the mental impairments that I see could be developmental disability, psychiatric illness, suicidality, aggressiveness, substance abuse, general medical conditions. But today I'm talking more about violence, and particularly those type of impairments, knowing that the others can occur too. But then if these violent tendencies occur in too many people in a population, or in particularly influential individuals, it can have a critical mass effect and have a greater effect than if we're just dealing with violence in a stray person here or there, but it can have greater impact. And we now live in a global community, and things that can happen in a remote corner of the world don't necessarily stay there. So that's basically what I'm saying. And now I'm just going to go into the details of this, explaining what I mean with each one of these steps. Now, in 2017, I gave a presentation at an ILADS meeting in Paris, where I said, if at some point in the future we had a pandemic that caused a type of mental impairments that increased the risk of violence, that could result in global instability. That was my hypothesis, and I explained it then. And that was in 2017. And then lo and behold, we did have a pandemic. So now let's look at that hypothesis and visit that, okay? Now, so if we think of violence throughout history, think of history that we had cycles where people work together and they collaborate, cooperate, and then there's cycles where there's conflict. And this comes and goes. And why is it sometimes we work together with compassion, cooperation, and empathy, and other times there's conflict and hostility? What causes those cycles to go back and forth? We need to understand every piece of that. Now, look at what we as humans have accomplished. We build skyscrapers, we've flown to the moon, we've conquered polio, we do great things, we make great medical advances, and that's happened throughout history. You know, it's not just recent years, it's been going on for thousands of years. But then there's also times when they have conflict. So how can people that do these horrific things to each other can also do these great things? So when there's the cooperation versus the conflict, what causes this dual potential in human functioning to go back and forth between these two cycles? Now, this is a particular concern now because it used to be conflict was fighting someone with your bare hands, but then sticks and stones and then more advanced weapons. A problem is now we have weapons that are very technologically advanced. And if technology guides everything, as technology changes, it impacts us in many ways. But we're finding this rapid development of weapon technology that's faster than the development of mental health technology to understand the people that could be in charge of these various weapons. And right now there's 12,000 nuclear warheads in the world. And that's rather scary, you know, where can we always count on stability with the people in control of that? At one point, America alone had 32,000 warheads. And when you think of it, you know, it's in August of this year, it'll be the 80th anniversary of the dropping of the atomic bomb. And right now there's 9 people that have impact over atomic weapons. And how many people will be on this list 5, 10, 20, 100 years from now? And what will the weapons be at that point? So we know aggression, it's a kind of a philosophical question. There's violence and there's aggression. And aggression is a normal part of human functioning. We compete, and aggressiveness can be good when it's well channeled, but violence is different, where there can be a ruthless quality to it. And we could ask, is that just a part of human nature? Or is it that, you know, is it a pathological consequence of something? If we see it as pathological, then we can possibly understand it and then figure out a way to treat it and prevent it and not be controlled by this violent tendency that surfaces in human functioning sometimes. So what I'm going to do now, I'm going to go back to my original hypothesis with the pandemic, but I'm not just going to look at the pandemic. I'm just going to look at this connection. Is there some connection between infectious disease and violence? And if so, then maybe that's one more way we can control violence. And when we look at violence, violence is a very complicated thing with many different facets to it. And we have to look at each one of those facets and try to intervene wherever we can. So to do that, I'm going to look at a series of questions that like connecting the dots. So these are the questions that I'm looking at. We look at environment, we look at those animal-borne zoonotic infections, and then can parasites have an ability to manipulate higher life forms? Are there animal models? Does violence ever make individuals pathological? What's the physiology? And uh, can violence on the part of one individual have a greater ripple effect on society and have more of a societal effect? Are there geographical patterns? If there is geographical patterns, are soldiers or visitors going to these conflict zones when they come back? Are they more at risk for violence? And what about the COVID? Did that epidemic result in more violence? And have other pandemics done it? And what if all this is true? Where do we go from here to try to get ahead of it? So we like to think that we're in control. We think, we see ourselves as a dominant species on the planet, although we're really not. And we're surrounded by microbes outside of us and within us that impact us in various ways in our environment and in our microbiome within us. We have more microbial cells than human cells in our body. So what about environmental change? That was the first thing on that sequence. Now, when you have environmental change, humans are slow to adapt. If you think of, let's say, a 20-year reproductive cycle, for example, our genes take a long time to adapt to environmental changes, whereas microbes that reproduce every 20 minutes or cycles like that have more opportunities to adapt genetically. So rapidly changing environments, and there's a lot of ways our environment's changing, and I can go into it, but you could go into these more details if you read the article that this talk is based on. And since the pandemic, we've seen a great increase of infectious diseases, not just COVID. So there's something about that, and I think COVID and the spike exposure to the spike protein has had some makes people more immunocompromised. And then you've seen activation of other infectious diseases, not just COVID. I've seen that with Lyme patients, but I've seen it, you could expand on that a number of ways. So if you think of this ecosystem, if there's healthy ecosystems, we have to think of ecosystems when they're balanced. Think of balance is the key thing, not extremes. There's some climate change, but there's always some climate change, and there's loss of diversity. That's something that can occur. Now, a lot of us have seen William Shatner on TV, where he talks about these exciting adventures to other worlds. And so at the age of 90, he went up in a spacecraft, and he was very disappointed because he said, we're living on an oasis of life surrounded by immensity of death, the deepest darkness and coldness in outer space. And he sees our planet as a island of life surrounded by emptiness and death. And I think that's true. So we want to protect our planet. Now, to explain a couple terms, zoonotic diseases are diseases that occur in animals, but then are transmitted to us. Vector-borne diseases are where there's a vector, for instance, a mosquito, a tick, a flea that takes that disease from them to us. And then One Health is a scientific, an evolving concept where we're trying to look at ecosystem health and animal health and human health all as one instead of having it fragmented. So zoonotic diseases have increased, and you particularly see these zoonotic diseases are often viral and vector-borne. So you think of people in proximity to animal reservoir. So it could be white-footed mice, it could be rats, it could be cats, it could be people that do outdoor work. So there's a lot of ways that we interface with this animal reservoir of these diseases that can go back and forth. And so in summary, vector-borne diseases are diseases that can be transmitted between animals and humans, and they can be spread by ticks, mosquitoes, etc. And examples are Lyme disease, West Nile virus, dengue fever, malaria, toxoplasmosis, Bartonella, rabies, avian flu, plague. They're all in this category of zoonotic diseases that are vector-borne, okay? And now this is another one of the questions. Do parasites manipulate the behavior of their hosts? How can something so small and insignificant manipulate a higher life form? But they do. And there's a lot of examples of this. It's called the manipulation hypothesis. It was first thought of with toxoplasmosis, but it's expanded. So animal microbes manipulate the behavior of their hosts in a way that allows their propagation. So it can alter behavior that can be excessive passivity, hypersexuality, increased aggressiveness, or other symptoms. Think of rabies, where being more aggressive then spreads it, but there's a lot of examples like that. So yes, parasites do manipulate the behavior of their hosts, their greater life forms. Do infectious disease contribute to violent behavior in animals? Yes, it does. Rabies is a good example, but there's many examples, and we did go into this in our microbes and mental illness article. And do infectious diseases contribute to violent behavior in humans? Yes. And look at it like encephalitis lethargica, we particularly found it. That was one of the two pandemics in 1918. But we've seen it with Bartonella, we've seen it with Lyme disease, herpes simplex, you see that. Measles, mycoplasma, neurosyphilis. Syphilis is a good example. Parvovirus, malaria, rabies, strep, toxoplasmosis, syphilis, viral encephalitis, and different kinds of viral type encephalitis. So there's a number of models with this, knowing that these infections exist in different geographical locations, and they're not equally distributed throughout the world. So what's the physiology? Now think of violence. What makes someone more or less prone to violence? I think someone that's particularly at risk, and three types of violence: predatory aggression, where you stalk and there's a ruthlessness and a lack of empathy; impulse control disorders; and psychotic and violence. Now think of the worst combination would be someone that has a large amount of fear, an excessive amount of fear, low impulse control, cognitive impairment, and they have predatory traits. Now, predatory violence, think of predators as like wolves, and that's a lower part of our brain. Think of your brain as developed from evolution, and your higher levels are more civilized when you go up and forward. But if you get overstimulation of a stimulatory pathway or failure of stimulation of inhibitory pathway on those different layers, then you can see violent behavior. But predatory violence is particularly a problem because there's lack of empathy and there can be ruthlessness. And that is particularly dangerous because then it's well planned and thought out. And there isn't a normal empathy. And empathy is a big thing that restrains most of us. So I've done work with criminal psychiatry over a period of over 50 years, be it in criminal places, an institute for the mentally insane, death row, or working with these people in my office, doing research. And you can see that people that have these tendencies, they're different. And one thing is we think of controlling violence with deterrence, that if you do a violent act, you will be punished. And that doesn't work for someone that has no impulse control, poor cognitive impairment, and has predatory traits. So you have to think differently and understand this. So when you look at violence, there's many contributors and many deterrents. You need a multi-system model. It's a very complicated model. I'm not saying that all violence is from infectious disease, but I think infectious disease is one piece of contributor to violence that we need to consider among other pieces. And we need to look at every single piece that contributes to violence or every failed deterrent. And when we look at each piece, I think we're doing better at guaranteeing safety and controlling violence. So in any violent act, there can be failed deterrents, there can be chronic contributors or acute contributors. And each case is different, but you often see this basic formula. And then when there's pathology, this is a simple way to think of it. When you're dealing with pathology, there's something that drives it, be it infections or other driver. Then they can cause symptoms. But some of these symptoms are immune mediated, where the immune system reacting to infection causes a lot of the symptoms that we think of associated with infectious disease. So you can get the symptoms from both those. And these three things interact. And we need to understand those interactions in understanding the causality, the pathophysiology, and also treatment options. So when we look at, let's say, the immune system, we can find there's this pro-inflammatory cascade, and you don't have to have infection in the brain. You can have it in the body. And then you see this, and all these infections have a very similar pattern with a pro-inflammatory cascade. The pro-inflammatory transmitters then impact the brain, and they alter how our brain chemistry operates, which then, and we see it with Lyme, we see it with HIV, malaria, toxoplasmosis, or other things. And I refer to this as the death formula. And with that, you see increased inflammation, increases in what we think of IDO, and that alters, like tryptophan is an essential amino acid. It should turn in as serotonin and melatonin, which is good, but instead it gets converted to quinolinic acid, which is neurotoxin, and that contributes to someone being homicidal or suicidal. Now, I wrote about this in a paper I did where we looked at a person. It was a Lyme patient, and he wasn't adequately diagnosed and treated, and he went on to be homicidal and suicidal. And then we did an autopsy, and we showed quinolinic acid in the brain, which shouldn't have been there, and we showed spirochetes in his body in spite of considerable treatment. Now, when this happens biochemically, what's going on in a person's brain? And this is what someone described to me, and I've heard this many, many times, unfortunately. And this is one case, but it's one case of many that I've heard many variations of. So a patient described overpowering, violent thoughts. At times he's intrusive, and sometimes people describe intrusive thoughts. It just comes. Violent thoughts that would be triggered by stimulation, such as a dog barking, a bird chirping, a strobe light, or the presence of other people. He would then have episodes of anger with an urge to destroy. He said he suddenly had the urge to rip the room apart, to kill everyone and every animal in the house. At times, he obsessed. He wished he had an excuse to go after someone. He particularly frightened that he would have these urges in the presence of children. He felt he could sometimes stop these urges by hurting himself. He described road rage out of nowhere and fantasies of beating and killing people. So when somebody cuts you off on the highway, be careful about getting into conflict with that person. You could be dealing with this person. As it turned out, this person was treated and they did improve, but there's a lot of people walking around with this in their head, and it goes with that biochemistry and that neurological impairment that I was talking about before. So if you think of this imbalance, empathy is the deterrent. Not everybody has empathy, particularly like sometimes herpes infections or certain damage to the certain part of the brain destroys empathy. So there isn't normal empathy. Empathy is something we take for granted, but when you work with some people that don't have it, it's very different, okay? And then there's impulse control, and then the fear and response to fear. So again, cognitive impairments, lack of empathy, poor impulse control, excessive fear, those are things that push someone in more of a violent direction. And brain dysfunction, brain injury makes someone more at risk for this. Okay. So I did a study where I studied 50 homicidal Lyme patients, and 49 of them were also suicidal. Now, I get calls from different attorneys, and sometimes it's church shooting, school shooting, or family homicide or suicide attempts, and they're all very similar. A lot of these people, then they kill other people and then kill themselves. It's a very common pattern. Or maybe they don't, or they try to, and it's a rather repetitive thing with the same dysfunction. So now cognitive impairments also increase the risk of violent behavior. And this is a study showing all the infections that contribute to cognitive impairments. If you go in a prison setting, many of those people are cognitively impaired, and that contributes to them being more at risk for violent behavior. And there's a long list of infectious diseases that cause cognitive impairments. And now, another study was done, and they looked at countries that had lower IQ with more cognitive impairments, and that correlated with greater infection load. Okay, and so infection clearly contributes to cognitive impairments. So it's we're looking both at cognitive impairments and emotional impairments. So the bad combination is when you have this physiology with the immune system and the neurochemistry, the neural circuits, where you have the cognitive impairments and the emotional impairments, the decreased empathy, poor impulse control, excessive fear, and predatory tendencies, that's a formula for disaster. But those things are associated with certain infections, and not everyone reacts to that same infection in that way, but some people do. Two people can have the same infection, and one person could react in this way and another one not. So then it raises the question, can healthcare prevent evil? Think of some of the evil people that like Vlad the Impaler down in the lower right-hand corner, some of them, what did infection ever play a role? And we'll never know because we just don't know with some of these cases. Now, particularly when you have impairment with predatory aggression, where there's this ruthlessness. And one thing that has been studied is syphilis. And syphilis, people would go back over history and say, well, did some of these people that committed violent behavior, did any of them have syphilis? Now, that's what all these people had in common. They were all considered to have syphilis. Now, if you look at, let's say, Hitler, he also had encephalitis lethargica. That was clearly associated with violent tendency. He also was exposed to gas in World War I. I did have a hypothesis that all the infections that were part of the trench warfare and all the issues surrounding World War I caused a lot of mental impairments that resulted in mental impairments of people that became leaders decades later that contributed to World War II. And these were some of the people and there's different degrees of evidence or suspicion about it. And often you find where they are ruthless when they were younger and then they deteriorated. For instance, back with Hitler, with encephalitis lethargica, you also often see Parkinson's with it. And he died, I think, at the age of 53, and there's evidence he had Parkinson's. So I think encephalitis lethargica was a big issue with him. And Lenin also, but not everyone who had syphilis had violence, but some people did. Okay. So in summary, I think there's history, but it would be nice, look at some of your people that were atrocious in history. How many of them there's no way of knowing how many of them may have had infectious diseases that contributed to their violence. Okay. So now, if it affects one person, that one person may harm their family, it may harm one person or a few people, but can it have greater societal impact? That's the question. So is there, now some societies that are well structured are good at containing it, but some societies aren't. And if too many people in a society have violent tendencies, then there can be this tipping point. So you can think of violence as a contagious disease. Violence begets violence. Somebody was violent to me, and now I use what's called identification with the aggressor, and then they become violent or they feel they have to be aggressive to protect themselves. And there's a critical mass dynamic. And I saw this running psychiatric units, that if you have too many people in a group of a certain trait, it can have a tipping effect and tip the whole society in the wrong direction. So if too high a percent or too many influential people have violent tendencies, it can tip the whole society in that direction. So now, is there geographical patterns with violence? Violence is not equally distributed throughout the world. And what we found is parasites are more prevalent in the equatorial regions and less prevalent in the polar regions. So if that's so, is violence more prevalent in equatorial regions and less prevalent in polar regions? Let's look at that, okay? So if we look at that, there's what's called the Global Peace Index, and that measures countries, which countries are more or less peaceful. And looking at that, the most peaceful country is Iceland, and the least peaceful country is Afghanistan. Now, what's interesting is, who's in Iceland? They're descendants of Vikings. So if violence were just a genetic trait, how can Iceland be the most peaceful country in the world? Look at Australia. Who lives in Australia? They're descendants of criminals that were sent there from the United Kingdom. And yet it's a very peaceful country. So it makes you think, I don't think genes are the major player. I think environment is. So what is it about these geographical locations that makes it different? Now, this is Afghanistan, and these are vector-borne diseases in Afghanistan. You don't have a chance living here. Look at all these vector-borne diseases that are in that. There's something about the environment there that's very dangerous with multiple vector-borne diseases. And not only that, but also other infectious diseases that aren't vector-borne that we really don't see in a lot of other places. Some of it's the poor hygiene, sewage, treatment facilities, poor water, food storage, all those things added together. Compare it to Iceland, where they don't have mosquitoes in Iceland, and they don't have ticks. And we see that same thing in these countries that are more higher latitude or higher altitude. In those countries, there's less of the vectors that would transmit the disease. This chart's basically looking at what's the risk of infectious disease compared to the risk of violence. And basically it shows that the more infectious disease, the more violence there is that correlates. Now here I broke down the 10 most peaceful countries compared to the 10 least peaceful. So the most peaceful: Iceland, New Zealand, Denmark, Portugal, Slovenia, Austria, Switzerland, Ireland, Czech Republic, Canada. They're more higher latitude countries or higher altitude, same ecosystem, okay? Whereas your least peaceful: Afghanistan, Yemen, Syria, South Sudan, Iraq, Somalia, Democratic Republic of Congo, Libya, Central African Republic, and Russia. Those are the least peaceful, okay? Now, this is before actually the effect of COVID, okay? And that's based on the statistics. So the least peaceful regions are repeatedly the Middle East. There's something about the Middle East where through thousands of years, it's been a conflict zone. And also sub-Saharan Africa and Latin America and Caribbean area. And they may calm down here and there, but often over years and years, they're more conflict there. So higher latitude, higher altitude countries, generally less parasites, less infectious disease, and less violent than places closer to the equator. There are exceptions, but this looks at basically disability adjusted life years is a measure of infection load. And when we look at this, this is the infection. Now you see higher infection closer to the equator, the darker area, and lower infection further away from the equator, okay? Now compare this to violence with risk, you see about the same areas. So these equatorial areas have the higher amount of violence and the higher infection load. It correlates not 100%, but pretty close, okay? And this is the Western Hemisphere, same thing. Look at where the equator is. And you see a higher amount of violence closer to the equator and a lesser amount of violence as you get in polar areas, okay? Now, Russia is an exception because that's a higher latitude area, but they have a lot of criminal behavior. We see it. Russia is a very big, complicated country with a lot of different ecosystems. They have a poor healthcare system. I think that contributes to it. But they also have a lot of tick-borne encephalitis, a lot of tick-borne and vector-borne diseases that could explain it in some of these areas. And as I say, a poor healthcare system. So Lyme disease, there was a study done. You think of Iraq as having a history of conflict, and they did a study in a mental hospital in Iraq, and 66% of the patients there were positive for Borrelia species, okay? So these are some of the articles I've done looking at tick-borne diseases and homicidality. Now, so in summary, looking at the geographical pattern, this is another article that was very interesting. Now you could say, okay, there's an association between infection and violence, but what comes first? Maybe the violence comes first and that causes infection. This looked at that and it said, well, when you see fluctuations, you see more of a pattern that the infection comes first and the violence comes second. Now the violence doesn't come a day after the infection. It can follow a long time. That's often, it takes a while for those symptoms to evolve, okay? So there's a causal association. geographical areas with violence, there's a causal association. Geographic areas with more infection, there's a causal association with violence. Now, if there's violence geographically, how about soldiers fighting in these zones? Do they come back with a violent tendency? It's hard to sort that out because when soldiers go there, they can be exposed to trauma. They're trained to kill, and then they come back. But even sorting that out, and throughout history, going back thousands of years, when you see returning soldiers, they often returned with different diseases, and they also often returned with more violent tendencies. We've seen that with Vietnam War. We saw it with Persian Gulf. We've seen it with a number of battles, wars where that's happened throughout history. So in general, I would say, yes, you can see that, but it's a weak association with returning soldiers. It isn't always so, but sometimes. Now, back to the COVID pandemic. Now, did COVID contribute to violence? Actually, it's very easy to answer this question because we found that the pandemic caused cognitive impairments, it caused mental disorders, and it caused substance abuse. We know all of those collectively can contribute to higher risk of violence. We also had studies that showed since the pandemic occurred, there was an increase of gun violence, an increase of violence against children, an increase of domestic violence, and an increase of elder abuse with different studies. So clearly, the COVID epidemic resulted in violence. Now, this is more on family, local level, but you also saw 2 wars break out afterwards. Did that play a role? Okay. So when we look at this and we look at the global peace index, and that's a way of measuring the peace, not just in separate countries, but in the world, we saw the global peace index decline independent of the Ukraine or the Middle East conflict that occurred. So it did seem that it played a role. So unfortunately, my hypothesis was clearly correct that this pandemic was associated having some causal effect. And we saw increases in these usual conflict zones that was occur. Like I said, it wasn't just Gaza, it wasn't just the Ukraine and Russia. In other pandemics throughout history, we've seen that pattern sometimes, but not always. Sometimes when there's been pandemics, there can be blaming certain social groups, and we can see genocide as a result of it. So there is an association with other pandemics with increases of violence, but not with everything. Sometimes people pull together, but there's a general trend. Okay, we particularly saw it with 1918 with the 2 pandemics that occurred then, and with HIV, we saw it. So we think of One Health maybe as we have to pull this together. You can't just look at psychiatry. You can't just look at infectious disease. You have to pull these things together. So a lot of people that don't normally work together need to work together and put their egos aside with like a One Health approach where you're looking at different scientific disciplines, humans functioning, animal functioning, and that gets back to my original hypothesis. We get a compromised environment, we get more pathogens, more infectious diseases as a result. There's the physiology that can be explained. Some of these mental impairments can be violence. If they occur in influential individuals or too many people, it can have a tipping point with critical mass dynamic. You can get global instability, which is a problem when we have advanced weapons. So to summarize, there is evidence drawing this association, but then, if we collaborate, we can help understand each of these pieces and do something to try to prevent it. But where do we go from here? Okay. What do we need to do in the future? What do we need to do if there's a future pandemic? So one is create a model that explains these regional differences. Okay. And in doing that, this is the model I came up with. If you have a deteriorating ecosystem and increases pathogen load, you can have zoonotic infections or non-zoonotic infections that are transmitted in other ways. Okay. Now, if I look at the zoonotic, for example, you have to have a host in proximity to humans. So, and then you need vectors that transmit it, but the vectors don't always survive in every climate. That's why higher latitude countries, you have less of the vectors that survive that might transmit it. Humidity and temperature plays a role. Okay. And then you have the other transmission, but if you have a good healthcare system and sanitation and food, protection, you do okay, and that can buffer this, even if it's an equatorial country. But then you get the infection, and then certain infections contribute to violence. That's the model. So it's in different countries, there are different pieces of this that contribute. So when we look at the variability with this formula, these are the variables: the ecosystem, the pathogens, how can it be transmitted, the animal reservoir in proximity to humans, the vectors, temperature, humidity, sanitation, healthcare system, social system, population density, okay, reliability of data. A lot of times we don't have data on this because these worst conflict zones, they don't keep good data. So let's compare maps and see how can we do this. So what are the usual suspects? This goes back to the article Microbes of Mental Illness. These were the infections we found associated with violence. And to break it down, they were the zoonotic diseases that we're aware of, the non-zoonotic diseases, and who knows what else that we aren't paying enough attention to, okay? And these are the vectors that can happen: ticks, mosquitoes, fleas. Fleas are a big one, lice, aquatic snails. Now, let's look at it. I'll use America as an example. Violence is not equally distributed throughout America. This is a map. It's the most dangerous cities. And if you look at this map, what's the pattern here? Now, it's a little bit different than what you see with Lyme disease. Look at South Carolina lights up, Florida, Louisiana. You see in the South, you see a strip going up the Mississippi River and up other major rivers in the middle of the country, and then out towards the West Coast, where there's humidity and warmer temperature. Now, what does that correlate with? This is a map of flea survival. So flea survival is really vector survival, and look at how close these align. Now let's look at infections. This is Bartonella, okay? Bartonella, how's Bartonella? Transmitted by fleas, okay? So here's Bartonella. These are vet statistics. Vets pay more attention to Bartonella than human medicine does, okay? So this is Bartonella infection, fleas that transmit the Bartonella, and this is violence, okay? So 1, 2, 3, okay? That kind of correlates, doesn't it? Now, it may be different infections in different geographical areas. So to sum it up, the world's a dangerous place, not just because of people are evil, but because of people who don't do anything about it to help fix it. So I've been talking about violence, and it's not because I'm fascinated with violence, it's because I want peace. And in order to ensure peace, we have to understand violence and do everything we can to prevent it and look at everything that may be contributed. And I think this infectious disease link is one thing we're ignoring that we need to pay more attention to. If we were more attentive to it, I think it's a way to help control violence. Okay, so that's all I want to say. And now I can, let me see, do the stop share, and we can talk about any questions that you have. Okay, I hope I didn't cover too much too fast, but I wanted to kind of do an overview.
You did cover a massive amount. Absolutely stunning. Thank you very, very much. I think this is really unique. I don't think anybody else has covered this information like you have. There were quite a few questions, so I'll go through as many as I can in the time.
Okay.
Let me just have a quick look. So one of the points made was, and I think you've covered this, but I'll just ask it again. Do you think that psychopaths and sociopaths mostly have some sort of brain infection, or is it simply genetic? You have covered that.
Every now and then I've seen it run a little bit in family, but I think the bigger part is there's some brain injury. A study on death row was that 100% of people on death row had neurological impairment and a history of abuse. And that's a bad combination. Now, psychopath is worse than sociopath. Sociopath don't care. And where psychopath want to hurt, they feel joy in like, I want to take the pain in me and put it in another person.
Oh.
Whereas the sociopath just doesn't care one way or the other. They have a lack of caring, but the other really, once they like torturing, they get gratification from it. And I think invariably most, I think, have a history of trauma that makes them hostile towards people. And I think most have a history of brain dysfunction. And I think as we get better brain imaging, brain chemistry, and I've never known a person who committed homicide that had a normal brain.
Incredible.
And I think there is something pathological. I don't think we're doomed that people are just murderers and we have to accept it. I think it's a pathological process, and we have to approach this the way we approach an airplane crash. When you have an airplane crash, you study it. This is what went wrong, and let's change the system so this doesn't happen again. We don't do that with homicides. We don't do that with criminal behavior. Instead, we say, well, let's see who's guilty, and we'll put him in jail, and then that solves it. And that doesn't solve it. It doesn't do anything that's preventative to correct things for the next thing to happen. There isn't an effort to understand and prevent. And that's what I find frustrating about our whole system.
No, what you're saying is so, so important. Thank you. Suzanne says she has seen clinically an increase in suicidal ideation. Have you seen that as well?
Yeah, I get that, and I think it goes with that pathway that I described with the quinolinic acid. And now some of that's the intrusive thought. There's a lot of reasons why people get suicidal. A lot can be anhedonia. And I've done an article rather extensively looking at suicide with Lyme patients. And in there, I talk about suicide in general, and I did a formula for suicide like I did for violence. And I think when you add it up, I think feeling no pleasure in life is a big thing. There's a lot of things that have a tipping point. People that have purpose and meaning, you don't see that. People have social connection, impulse control. And I think suicidal versus violent, suicidal people do tend to internalize aggression, whereas violent people may externalize it more, and some people do both.
Yeah. Gaia says that symptoms like lack of sympathy could possibly be caused by lack of oxytocin functionality. She wonders whether that could be an effect of infection.
Yes, absolutely. And oxytocin, now here's a good example with that. It's proof of that. You take a sheep and they give birth, and after they give birth, then they bond to the sheep, okay? The baby. If instead you do a cesarean section, that same mother will kick the baby. Okay. Now, I've worked with mothers that kill their children at childbirth. And in those cases, a lot of times they didn't know they were pregnant, or they denied it. And they may have had a traumatic birth, and it looks like a foreign body coming out. And they don't have the oxytocin wasn't primed. You have serotonin that primes the oxytocin. So oxytocin is part of bonding. When you look at bonding and empathy, oxytocin is a big part of it. So oxytocin is one of the pieces, the neuroendocrine component to bonding, and I totally agree with that.
Amazing, thank you. Susan asks, how did such mentally ill people get so much power? Is it the power of the parasites? She wonders.
Well, I think sometimes the parasite can make some people ruthless, and they do things no one would ever dream of doing. Okay. And a lot of these people that, like when I showed that chart, they do things to get power that how can anyone ever do that? So you don't prepare and defend yourself. And that's how they get power, by their extreme degree of ruthlessness that the average person would never dream of doing. And so they get it in ways that is hard. We like to think that everybody's kind of like us. And maybe they're misunderstood, but they're kind of like us. And when you work with someone who's truly psychopathic, you realize how different they are. They're very, very different. The closest thing you compare it to is sometimes they do these videotapes of serial killers and they interview them. You can't look at movies because movies are actors. Yeah. And actors sometimes act, but you don't get the real feel unless it's the real person, unless you're sitting with one of these people and they treat you like an object. They don't treat you like a person. there's a lack of human connectedness that some of these real psychopathic people have.
Absolutely. Julia mentions that there are obviously a lot of geopolitical and social/religious factors involved, while Gaia and Alessandra do say perhaps these geopolitical and socio-religious factors are being influenced by such infections. It's a difficult balancing.
Right. Now, I did write about that. I went into more detail in my article. And there are societies that are more structured, where they give more freedom and recognition and upward mobility and less corruption. But when you have people that lack empathy, who are ruthless, who are in control of the societies, the government, they structure it in a more ruthless authoritarian manner. And so that it can be entrenched within the society. And a lot, like, look at religion. It's not so much religion, but people can use religion and quote it and take it out of context. People can take anything out of context and use it as an excuse for violence.
No, it's an extremely complex field that you're grappling with here, global statistics, but fantastic work. Dr. Schwarzbach has a question here. He says Napoleon's army was stopped from typhus infections by lice in 1812, with massive killing and losses of his army in Russia, with high fever and other lethal symptoms. What do you think about the hypothesis of laboratory manipulated pathogens causing violence, such as war syndrome?
Well, I think that can happen, and there's some question about that with Lyme disease, or some of these, that was a question with COVID. And it was a question with some of the experimentation in World War II. And there was a biological weapons program, like Chris Newby wrote about this. And in that, it's like, well, is it Lyme, or is Lyme just a marker for tick-borne disease? And is the real marker what was called the Swiss agent, or some other rickettsia, some other agent that's there? And you test positive for Lyme, or you have the symptoms, but it's really something else. And a lot of these people think of Babesia, Bartonella, Borrelia. It could be relapsing fever. It could be rickettsia. It could be toxoplasmosis. So it's a complex interactive infection. And you get immunosuppression, and then these other pathogens get activated. And it's a complicated thing that then causes this. So it's a certain infectious mix that comes out. Now, with a lot of war, most people died from infection rather than war. Okay, and that happened with Napoleon, and it's happened. A lot of wars were like that. Think of the Europeans' conquest of South and Central America. 90% died from the diseases they brought there. Now that happened the other way, whereas the population, where here we're talking about his army, and they're in stressful, compromised situations. Now, all this experimentation that we did, and there's questions about Plum Island. I don't think it's Plum Island so much as they were doing these experiments everywhere. And it was fairly reckless and careless, messing with something. It's like just because you can do it doesn't mean you should do it.
I know Professor Garth Nicholson has spoken to us about that as well.
Yeah, I think I think there's some of that did occur, and I think that's happened, and I think it's irresponsible research that we call it gain of function research, but it could have been other research that was done.
Yeah. There are questions here about whether one can actually heal this kind of brain damage. Susan says that Dr. Klinghardt has mentioned that when Napoleon fought the Russians appeared to have survived because they did the Kozakov treatment, that is homeopathic ingestion of urine after percussing it and throwing up the liquid 3 times. That's fascinating, isn't it?
Yeah, actually, there's theories about that, where certain things are transmitted with dogs, where they lick urine, and usually people don't do that. Although every now and then you have a type of psychopathology where that might happen, but it's And actually, they used to do that, I think, basically when penicillin was hard to find, when in short supply, they would extract it from the urine. And so it's hard to know what it is that might work, or there's so many variables that push you in a bad direction or help you to overcome it. You have to tease out all these complicated variables.
Absolutely. I'll just pop over to the Q&As because I was focusing on the chat and there are Q&As as well. There's one, of course, very complex question to begin with, which is, what have you found to be a main contributor for OCD, and is there anything that can help OCD?
Well, I think there's two parts OCD. OCD is an imbalance of doubt versus assurance pathway. Now think of doubt versus assurance. And people that have OCD, doubt is more powerful than assurance. A part of OCD can be intrusive symptoms. That can be step one, where I get an intrusive symptom that my hands are dirty, let's say, or whatever it could be. It could be anything. And then once that comes, then you doubt, and then you wash your hands, but you're not assured they're clean. So then you keep doing it. Now, it can be many things other than, I'm using hand cleaning as an example, but it could be many other things. So so then you want to treat the intrusive part if that's significant. And then you'd also want to treat the looping, the failure of assurance. That's where we use more of the SSRI type treatments. And I think there's an autoimmune piece that causes that in the first place. And like an example would be PANS or PANDAS, where someone gets a infection, they have an autoimmune encephalopathy, and then all of a sudden they have an acute onset of obsessiveness, right? Mm-hmm. So there's like a basal ganglia autoimmune encephalitis that then damages that circuit that makes you more prone to intrusive and doubtful thoughts doubtful emotions that drives the thoughts and the behaviors.
Thank you. Yes, there are quite a few questions here. I don't think we're going to get through all of them, but Vicky, for example, asks, have you found that the infections leading to increased violence are seen equally across the genders? That's an interesting question, isn't it?
I've seen it with women, but
yep.
I think men are more prone to be violent tendencies. Men are more power. I think men are more controlled by power, women more acceptance, social acceptance. And I think male violence is more, I can beat you up, I can beat the crap out of you, whereas female violence is, I'm going to ostracize you, reject you. So I think I have certainly seen some violent women, but I think generally testosterone, males are more prone to violence. Although one exception is a nursing mother. Don't ever get between a mother bear and her cubs.
Oh, yeah.
And then you can see what oxytocin does. So when you get an oxytocin, prolactin, excuse me, I meant to say, when you get a prolactin secreting hormone, a high prolactin level, that goes with violence. It's the protective mother. So in that case, you can see a lot of violence with that nursing high prolactin mother. Okay. Right. So and then you can see it also like in PMS sometimes with dropping hormone state, but that's irritability. It's a different kind of violence.
Mm-hmm. There was a lot of interest in your mention about suicidality as well, as a sort of correlation to what you've been talking about today, violence. You said you had done a study and an article on that as well.
Yeah.
Could you possibly send us the name of that article after this?
Well, that was my study with Lyme disease and violence and suicide. And there I looked at it, and part of it was a lot of people were frustrated. They were lost in the system. So there was a societal part. My family doesn't understand it. And, that's a part of it. But the other part of it can be the physiology of it's there. Okay. Mm-hmm. And the lack of pleasure of life, if it does that, and all the added impairments. So there's multiple ways. And Dr. Fallon also did a study on Lyme and violence. He did it in a different way, but he came up with many of the same kind of findings that I had. Yeah. So my article was done in a number of years ago. So do Bransfield suicide Lyme, you'll find it. You can Google
Yes.
it easily.
Michaela will send that out when we send out
Okay.
the e-blast after this with the recording. Thank you. So I don't think we have time to answer any more of the questions today. We will save them all over in the hope that perhaps we can get you back again, perhaps to focus specifically on the suicide aspect, which is of course more personalized as against the sort of global violence aspect, which has been absolutely fascinating today. Thank you so much. And the focus on One Health as well is interesting going forward. Is there anything you'd like to finish up with?
I'd like to say, I'm mostly a clinician dealing with one patient, one case at a time. And this is a societal issue, but once I see it, I felt I had to share it with other people and explain. And I think anyone who sees this, you want to do whatever you can to spread the word, share this.
Absolutely.
I hope other people think about this. If it makes sense, share it with someone who can impact policy, try to make a difference. It's a big thing. If we can do something that prevents violence, let's do it. And we all have our own issues and that we have to deal with, but sometimes you want to do something that helps us have a more peaceful world. And I realize there's a lot of people that fight us that say it doesn't make sense. And, but it does make sense. It all fits together. And you really have to think outside the box and it's spread the word, help. I can't do this alone. I can't be the only one preaching about this.
No. Well, maybe we can have you back again to answer more of the questions here, because there's quite a few still that we haven't got to, and to give us a sort of an update on this. Absolutely fascinating. Thank you so much.
All right, thanks. I hope it's thought-provoking. Okay.
Just 1 minute, if you don't mind staying on. Do leave if you have to. I just wanted to mention that our next webinar is on the 1st of April, and Dr. Ray Perrin will be talking about Through the Looking Glass, Long COVID and the Perrin technique. And there are definitely overlaps between what he'll be talking about and this. And Dr. Lee Cowden will be speaking on the 10th of April to answer questions that came from our last webinar. Otherwise, please do look at our upcoming webinars, because we do have wonderful webinars ahead, and events as well. We'll be at the IPM with Professor Craig Shimazaki, who you know, of course, Dr. Bransfield, and he'll be talking about related issues as well. He'll actually be there live at Westminster. That's on the 20th of June. So thank you, everybody who's been here as well. Thank you very, very much for spending the time with us this evening. The recording will be up on the website within a few days. So all of this will be immortalized and we'll be able to share it, Dr. Bransfield. Thank you very, very much indeed.
Thanks. Bye.
Goodbye.